In this recorded series, we're going to talk about arthritis. We're going to specifically talk about osteoarthritis, rheumatoid arthritis, and gout. Systemic lupus is in the arthritis section just because SLE is an inflammatory disease, and over time it does affect the joints. So let's talk first about osteoarthritis. So osteoarthritis is a type of arthritis that affects the articular cartilage. So over time, the joint will wear the cartilage down, and the individual will become bone on bone. There will be no cartilage left for that patient. So osteoarthritis is considered a non-inflammatory type arthritis. It is chronic, it's progressive over time, and it usually involves the larger joints, the weight-bearing joints, like the hips, the knees, the spines, and the hands. So one of the things that's really important to remember in osteoarthritis is, generally speaking, it is asymmetrical, meaning that there's not bilateral involvement, which is a distinguishing factor from rheumatoid arthritis. So osteoarthritis, generally speaking, is asymmetrical. So it's a non-inflammatory disease of the synovial joint, and the joint will become hard and bony. So over time we lose that hyaline articular cartilage, and a lot of times patients will develop bone spurs, which we call osteophytes. So you'll see on X-ray that there'll be a narrowing of the joint over time, and you can feel crepitus, which is that crackling or popping when a patient moves their joint. It's a grating sound or sensation. And the patient will have joint pain and stiffness with decreased mobility. So all joints can be affected, but most commonly it's those weight-bearing joints, what we call the wear and tear joints, and it's usually asymmetrical. Age sometimes is a factor. It usually begins between the 5th and the 6th decade of life. It can be as a result of an injury or trauma, or just wear and tear. And of course, obesity is going to contribute to that, because the patient's going to have more weight to carry around. So we do know that it does affect women during the menopausal period of time, because they have a decreased amount of estrogen, which is important for joint health. So let's talk about some of the hallmarks. What are your patients going to look like? So they can have the Heberden's versus the Bouchard's nodes. So you'll see that the Heberden nodes are distal, okay? They're distal. They're those bony outgrowths that you can see right here, closest to the nail bed. And the Bouchards are the ones that are going to be proximal, closest to the body. So usually what happens is that upon awakening in the morning, the joints are stiff and they're usually painful. But that only lasts about 30 minutes. Once they get up, once they start moving, that stiffness will subside, the pain will subside, and it within about 30 minutes or so, once they start moving. But what will happen is, as they use these joints throughout the day, the pain and stiffness will really increase during the daytime, and when at the end of the day, they will experience pain and stiffness secondary to the insult that the joints have had all day long. Okay, so this is a type of arthritis where they will wake up with pain and stiffness in the morning that goes away with movement, but you'll see that these patients will have pain at the end of the day after they've used these joints. Okay. So clinical evaluation, of course, it's important when you are evaluating anybody, you want to rule out any other type of possible arthritis, like for example, rheumatoid, because that carries with it, it is an autoimmune disease and carries many different ramifications. So what you're going to do, what you will see is that these patients will it's usually one of the larger joints, knees or hips, and you'll see that an x-ray is done and you'll see that narrowing of the joint space, and sometimes you'll see bone spurs if they formed, and you'll see whether or not the patient is bone on bone. And then when you want to get an examination where you can see everything a little bit better, of course you're going to get an MRI of that joint. So of course, there is no cure for osteoarthritis. It is something that happens usually in the latter stages of life. Usually what we do is conservative management, which is heat and cold and rest. And of course, if your patient's overweight, you're going to want them to reduce their BMI. For osteoarthritis, the drug of choice usually is Tylenol first, and NSAIDs later if Tylenol is no longer working. And of course, surgical management. So sometimes they'll go in and they'll do an arthroscopy and kind of clean up the debris in a joint, and sometimes they'll have to do a total joint replacement. So we do want them to exercise. We want them to have obviously low impact, things like the stationary bike, water aerobics, maybe some weight training, because we always want the muscles that surround a joint to be strengthened, because muscles are the thing that support our joints. So if we're talking about knees, for example, we want our patient to increase the strength of their quads. So that's about it for the evaluation of OA. So let's talk about gout. So gout is a type of arthritis that is due to an excessive production of uric acid, and those crystals that are formed by uric acid are deposited in a joint. It's very painful, and you'll see that individuals who have gout, they will have exacerbations or flares of their gout. So men are 3 times greater than women to develop gout. It usually happens between the 3rd, 4th, and 5th decade of life. But in women, it can certainly happen after menopause. They will have an increased incidence of gouty arthritis. So uric acid is the byproduct of purine catabolism. So purines are those crystal compounds that form when a purine is broken down. So that's why it's important that you understand what foods, for example, can affect the diet or affect gout, for example. But purines, just in and of themselves, you know, all of us have purines. The body, when we break down our cells, when we have cell death and the renewal of cells, in that process, we are producing purines. So it's going to happen whether you're eating foods that are higher in purines than others. So 90% of uric acid is reabsorbed by the body, and 10% of it is excreted in urine and in feces. So there does seem to be a genetic link in certain individuals who overproduce purines, which leads to a higher concentration of uric acid. And there are certain medications that can also decrease uric acid excretion. So those drugs are beta blockers and the loop diuretics. So diet is important. So we have to look at, you know, the risk factors. And we know that, well, there's some increasing evidence that supports that gout is associated with metabolic syndrome. So more specifically, when they did some trials and they looked at human studies versus animal models, it suggested that hyperuricemia, or an increased uric acid level, plays a role in promoting inflammation, hypertension, and even cardiovascular disease. So there's some things that have to do with fat, with inflammation, with glucose and insulin dysregulation, and liver disease when we're talking about gout, okay? Not everybody with a high uric acid level will develop gout. So you must have two processes in place for gout to occur. High uric acid, for example, and inflammation. So what kind of foods are high in purines? Well, we know that red meat is. We know that the organ meats are. Foods that are very high in fructose corn syrup, we need to ask our clients to stay away from all of those kinds of things. And my goodness, there's high fructose corn syrup in just about everything. We also know that there's an increased propensity when people eat shellfish and seafoods. Sardines have the highest level of purines that are known. And of course, alcohol also will increase uric acid levels, especially beer. So what are you going to teach your patient to eat? Foods that are low in purines, and things that we should all be eating as well for a healthy diet. Things like nuts and legumes and eggs and fruit and fresh vegetables. Now, there are some vegetables that you want your clients to stay away from. Things like asparagus, cauliflower, spinach, mushrooms, and green peas. Encourage whole grains, low-fat dairy products, poultry, crabs, salmon, and herring. Those are some of the good things that you can encourage. So gout, there's going to be an increase serum and urine uric acid levels, and so those crystals, those uric acid crystals, are going to deposit in this joint, and it's going to cause swelling and inflammation of that joint and pain. So what are we going to do for those patients? We're going to immobilize the joint because we want it to rest, we want it to heal. You can apply heat or cold, and sometimes these individuals can get an intra-articular, an injection within the joint of corticosteroids that will help decrease some of the inflammation and the pain. Medications that we can use, so for acute attacks of gout, we can use colchicine, which is has anti-inflammatory properties, but it doesn't have any analgesic effects. So you'll still have to give something to your patient like an NSAID to control pain. So colchicine is for inflammation, and you'll still need to give something for pain. Also in the acute phase, you can give corticosteroids, as I mentioned. You can give it intra-articular. You can also give it orally. So to prevent another attack of gout, one of the things you'll see that your patients will be on will be allopurinol. And allopurinol is a xanthine oxidase inhibitor that decreases the production of uric acid. And so it's going to be, you're going to see your patients on that. It's a very common choice to give them. And then, of course, we want diet control as well. So in these patients, you need to monitor their urine output. So we're evaluating output and the renal markers because what can happen is that these crystals can deposit in the renal tubules, and if that happens, we're going to have a decrease in urine output, some oliguria. So we're looking at output because, as I said, we're going to excrete some of the uric acid crystals in the urine, so we want to make sure that we have good kidney function for these patients. The last arthritis that we're going to talk about right now is rheumatoid arthritis. So we know that rheumatoid arthritis is in the autoimmune category. And so rheumatoid arthritis affects the synovial lining, that this little nice glistening thing that's on the end of each of our bones. And what happens to that lining is that it's going to thicken, and the joint space will narrow over time, and it can actually even become fused together. So there'll be no more bend, if you will. So some of the risk factors, we know that all ethnic groups are at risk. There are some that are higher than others. The peak incidence is again between the third and the fifth decade of life. It affects women 3 times greater than it affects men. There is thought to be a genetic link, and the differentiating factor of rheumatoid is that there are systemic effects that are associated with rheumatoid arthritis. Unlike osteoarthritis, where that arthritis is just affects the larger joints, and gout only affects the joint as well. Rheumatoid arthritis has systemic effects. So rheumatoid arthritis is a chronic systemic immune disease. It's marked by the production of autoantibodies known as rheumatoid factor, or RF. And so what happens is these autoantibodies are going to be formed, and then the rheumatoid factor is going to be combined with IgG, and there's going to be an immune complex that's formed, and those complexes are going to be deposited in the synovial fluid membrane of the joint. So these complexes are going to lead to some complement activation, which results in sparking the inflammatory response and destroying the connective tissue and the synovial membrane. And so the key to rheumatoid arthritis is that there is inflammation that is going to be present. So in osteoarthritis, I told you that the joint will probably be hard because there's osteophyte or bone production. In rheumatoid arthritis, you're going to see inflammation at the affected joint, and that joint's going to be red, it's going to be warm, it's going to be swollen, and it's going to be boggy, meaning that it's not going to be hard, it's going to be kind of squishy, if you will. So the synovium is going to be inflamed. The white blood cells are going to have invaded the synovium, which is going to cause a thickening of that layer and a fibrosis to occur there. So remember that the joint space is going to narrow and it's going to decrease, and later on, possibly, you can have ankylosis, which is that fusion of that joint, which is going to make it actually not be able to complete its normal function. I think I've told you all of that. RA can affect all joints. It is symmetrical. And it can be progressive. Okay, it is progressive. What are some of the complications that can happen is, as I told you before, it affects the joint symmetrically, but it can have some systemic involvement. Most commonly, the joints that are affected are the fingers, the wrist, but it can also affect the ankles, the feet, the neck, the shoulders, the elbows, and it can also cause problems with your eyes, so they can have things like scleritis. They can have heart complications, and I have some of those things, I think, on the next slide, and we'll talk a little bit about it. But when we talk about heart complications, we're talking about atherosclerosis, pericarditis, myocarditis. You can have some lung complications, some cancers as well. So how are we going to manage these patients? We're going to give them drugs that are going to modify and slow the course of the disease, and we're going to treat the exacerbations. We're going to manage the symptoms. We're going to use rehabilitation when possible. What we want to do is keep these patients as independent and functional as long as we possibly can. So rheumatoid arthritis for clinical manifestations, all the joints that we already talked about are at risk. And one of the differentiating factors is that it's going to be symmetrical. So if it happens on the left side, it's going to happen in the same joint on the right side. The joints will be what I already told you: warm, soft, tender, boggy, swollen. There could be some nodules, and definitely over time you'll see some joint deformity. And I'm sure you've all seen somebody with rheumatoid arthritis. So the caveat here is that they're going to have joint pain and stiffness, which is worse in the morning hours, for 30 minutes or greater. Remember that in osteoarthritis, it usually lasts up to 30 minutes, but in this population, we're going to see it last longer than 30 minutes. They can have systemic effects, fever, fatigue. They can have cardiopulmonary involvement, and they can also have anemia as well. So they have a lot of limited movement. Sometimes they'll have muscle contractures over time with atrophy. So you want to also palpate your patient when you're assessing them for lymphadenopathy. You want to make sure that you check them, their temperature, their peripheral circulation. Make sure that you auscultate their lungs, because remember that these things can have systemic effects. What else? I think that's about it. These are the joint deformities that you're going to see for these patients. That's different than what we saw in our other patient, our osteoarthritis patient. So here we have the swan neck deformity, which is the middle joint of a finger is extended. It's bent backward more than normal, so you can actually see that in this patient. The joint is flexed and bent down. And here is the opposite, which is the boutonniere deformity, where the finger is permanently bent downward at the middle joint, and the end of the joint bends backwards. Okay, so you can see that this part of the joint goes down and this part of the joint is bent, if you will. Here are the joint deformities of the feet. You can have an ulnar drift, which is a hand deformity where there's swelling of the metacarpal phalangeal joints, the knuckles, which are at the base of the fingers, and the fingers become displaced and they actually drift toward the pinky. So you can see that there's some outward movement. So now in the halcus valgus, you can see that there's bunion formation. You can see that there's, again, lateral deviation where that great toe is on the first metatarsal is on the great toe, and you can see that they also have that lateral deviation, just like the ulnar drift, where the hands are going to deviate towards the pinky. Okay, so let's talk about the medical diagnosis that is associated with rheumatoid arthritis. So sometimes the autoimmune diseases are very difficult to diagnose, because these patients will come in and they're going to have some very vague symptoms. A lot of times they're fatigued. Sometimes that level of fatigue is overwhelming, and they just don't feel well. They have malaise, they have muscle aches and discomfort, and sometimes they already have some joint deformity when they come in, and they usually have a decrease in appetite. There's not a single diagnostic tool that's available at the present time that definitively diagnoses RA. So it is diagnosed by laboratory data and the signs and symptoms that the patient presents with. So in 80% of patients with rheumatoid arthritis, their rheumatoid factor will be positive. And when you can do a titer with rheumatoid factor, and when they do have active disease, you'll see that those titers will increase. So you can also check the ANA on these patients, and a lower percentage, like 20 to 30% of people have a positive ANA when they have RA. But many times, when you're working these patients up, you'll see that an ANA is ordered, a rheumatoid factor. You're also going to see that a CRP and a sedimentation rate are ordered. Now, these two tests are not diagnostic, but they do give us some insight into how much inflammation is in the body at any given time. And also they're great markers to use once you start treatment, because once you start treatment, if you're on the right path, these markers should decrease. The inflammatory process should decrease with time. And a lot of times you'll see that there's rheumatoid arthritis bundles or packages for these tests as well. So they can also take a synovial fluid aspirate from the joint and take a look at that, and they can do an x-ray as well. Remember that the x-ray is not diagnostic. They're looking for a decrease in joint space. So those are the kind of things that you're going to see when your patient is being worked up for RA. So some of the nursing diagnoses that are associated with rheumatoid arthritis include chronic pain, and of course they can have acute on chronic pain. So they're going to have periods where they're pretty stable and periods where they're going to have exacerbation. So that's really what's important. They can have impaired physical mobility, and what we want to do is make sure that we keep those joints as healthy as we can. So during exacerbation, we do things to keep those joints safe, and we're going to talk about that. So of course, if you have deformed joints, sometimes people will have a body image disturbance. It may come to the point where they aren't even able to care for themselves, and of course sometimes people have, like with anything, a knowledge deficit. So our goals in treating these patients are modifying and slowing down the progression of disease if at all possible. We need to recognize when we have an acute exacerbation and treat the exacerbation accordingly. We want to manage the patient's symptoms so that they can be as independent for as long as possible and live a productive life. And of course, we're going to use rehabilitative care to keep the patient as independent and functional as we can. So what are we going to do to treat these patients? Well, a lot of times they're going to get NSAIDs, because we know that the NSAIDs are non-steroidal anti-inflammatories, and that helps to decrease inflammation and thus decrease pain. I think I said increase, but I meant decrease inflammation and pain, if I did say that wrong. And of course, this is also a group of individuals that are going to get some corticosteroids, which we all know that the effect of corticosteroids is immune modulation, which is going to cause them to have a decreased immune response, which puts them at risk for infection. One of the most common things that are used is the DMARDs. The modifying drugs are going to help to decrease the effects of rheumatoid arthritis. And one of the ones that is commonly used is methotrexate. It's one of the drugs that is used early when a patient is diagnosed because it has lower toxic side effects. However, it can cause bone marrow suppression and hepatotoxicity. So if you have bone marrow suppression, just like because we use methotrexate for lots of reasons, we use it with our patients that are oncology patients. We also use it in, for example, ectopic pregnancy, but it's also used in some of these autoimmune diseases. So if you have bone marrow suppression, you need to be looking at all three of your cell lines. So is it affecting my white blood cells? Is it affecting my red blood cells? Is it affecting my platelets? Or is it affecting all three of them? And when we're talking about hepatotoxicity, when we're looking at labs, we're going to be looking at things like ALT, AST, maybe bilirubin. Is our patient showing any signs and symptoms of liver involvement, liver failure? Okay, so make sure that you think about those kinds of things when you're giving drugs. Plaquenil, luflunomide, those are some of the other DMARDs. Now we have the biological modifiers, which are drugs that are given, and of course given periodically to help to manage and keep the rheumatoid arthritis at bay. So you'll see a lot of patients will use Enbrel and Humira at home. Things like Remicade, Orencia, and rituximab need to be given in an infusion center, and they're usually given in a cycle or monthly, but Enbrel and Humira can be given at home. And so you'll see some of these biological modifiers given as a reduction to keep people out of an acute phase, and you'll see some of the other ones are used during an acute phase. So let's see what else. Some of these drugs like sulfasalazine and hydroxychloroquine require a baseline eye examination. Those things are going to be added to the regimen when the patient has moderate disease. So luflunomide, which is one of the DMARDs, is it's really important to counsel your patients about the prevention of pregnancy, female patients obviously, because you can cause some birth defects if you become pregnant while you're on this medication, okay? And then an immunosuppressant is Imuran. You'll see your patients on that as well, okay? So I think that concludes the information that I have for you on the arthritises, which are osteoarthritis, rheumatoid arthritis, and gouty arthritis.